Welcome to today's video. We will talk about gynecomastia, its clinical evaluation, and management. So gynecomastia is defined as the enlargement of the male breast from increased glandular tissue proliferation. And it's also important to distinguish true gynecomastia from pseudo-gynecomastia, because pseudo-gynecomastia usually occurs as a consequence of excess adipose tissue. Pseudo-gynecomastia can also be referred to as lipomastia. Okay, and then as with any breast enlargement, it is important to realize that men can also develop breast cancer, so it's important to screen for this as well during the evaluation for gynecomastia. So what are the clinical features? Well, I used the term true gynecomastia, and this is important because oftentimes patients are referred to the clinic for presumed gynecomastia and are found to have pseudo-gynecomastia. So what is the clinical feature of true gynecomastia? It can range from a small, tender subareolar disc, okay, or it can go all the way to a full female breast, as you might find here in a man. And it can be either unilateral or bilateral. Oftentimes it is painful tenderness on touching, and this can be a source, obviously, of psychological stress in a biological male. A key distinction is that true gynecomastia actually involves glandular tissue, so you have proliferation of glandular tissue, while pseudogynecomastia is actually a proliferation of adipose tissue, hence the difference. So what are the histopathologic changes? Primarily there is duct lengthening and branching, okay, and however there is no alveolar formation, and there is evidence of epithelial hyperplasia as well in patients with gynecomastia. And the reason for this we will discuss shortly would be a decrease in the androgen to estrogen ratio, leading to breast tissue proliferation. So the etiology can be either physiologic or pathologic. The physiologic states occur in the neonatal period, especially with transplacental transfer of estrogen in a newborn. They could actually develop with breast budding. Also, during pubertal growth as well, that when there is an initial imbalance in a male between estrogen and testosterone. So there's a bit of a decline in the surge in testosterone, and for that reason, pubertal boys can also develop gynecomastia. And over time, with aging, you could have involution as well, being a cause. So the normal hormonal changes, or this could be due to transient estrogen excess, as I mentioned earlier. How about the pathologic causes? And this is what we are more interested in. So always look at medications. So medications are a known cause: hypogonadism in a male, cirrhosis, hypothyroidism really has to do with sex hormone binding globulin, and we'll review this shortly. Tumors, okay, so we don't want to miss those as well. And this can also lead to an imbalance in androgen and estrogen ratio. So the physiologic states, as I mentioned, is a maternal estrogen transfer. This is known as a witch's milk. Pubertal gynecomastia occurs in about 50% of boys, and it's often bilateral and tender. And it's important to reassure these patients that it will resolve in about 1 to 2 years in up to 90% of patients. On rare occasion, it may last into adulthood. The involutional cause is mild gynecomastia in older men and is likely due to a change in the androgen to estrogen ratio, or a decrease, obviously, in testosterone levels with age. And this would be the cause of that imbalance between estrogen and androgens, leading to gynecomastia. So the pathologic causes, we will look at them shortly as well. So let's look at the medication-induced gynecomastia. So a common drug would be spironolactone, which is used in chronic liver disease and hypertension, heart failure. Antibiotics or anti-infectives, so ketoconazole is a common drug as well. And then alkylators used in chemotherapy can also cause gynecomastia. And this is an older drug, cimetidine, not used as often as it used to, but it is used for peptic ulcer treatment, and that can also cause gynecomastia. And the more common drug now, digoxin, used in cardiac arrhythmias and heart failure, can also cause gynecomastia along with methyl dopa. So always important to take social history, because marijuana use has been associated with gynecomastia. And in these patients, if they were to quit marijuana, this would lead to resolution of gynecomastia as well. And of course, think of exogenous hormones. So the patients on estrogen, androgen, are they being exposed to excess androgens like and anabolic steroids, as for example would be bodybuilders. Okay, HCG can also cause gynecomastia. And then psychotropic medications such as the phenothiazines also associated with gynecomastia. So when a patient presents with this, I'm reviewing the med list. So review the med list and try and tease out whether patients on any of these medications during your evaluation. So let's look at the pathophysiology. So for anti-androgens such as spironolactone, they block testosterone receptors and also increase aromatization of testosterone to estrogen, and consequently, due to excess estrogen, there is a reduction in gonadotropins, and all of this ultimately feeds back and results in gynecomastia. How about antibiotics or anti-infectives? So ketoconazole, its primary mechanism of action is that it inhibits testosterone synthesis. Alkylators have various mechanisms of action or hormonal effects, which we wouldn't be reviewing today. And then how about cimetidine? It also has anti-androgenic effects, so it blocks testosterone receptors, leading to overstimulation of breast tissue by estrogen. So the other mechanisms kind of shown here, and I'll pause briefly for you to go through them for the So how about the pathophysiology of gynecomastia? We've been going through this a few times today. It blocks testosterone receptors. An example will be spironolactone. It increases peripheral conversion of testosterone to estrogen. It increases testosterone clearance, hence leading to a reduction in testosterone levels and consequently a disproportionate increase in estrogen levels. So this imbalance is what leads to gynecomastia, and also a decrease in gonadotropin secretion, which ultimately results in low testosterone. So for hypogonadism, as a cause of gynecomastia in males, it will be primary testicular failure, as would be seen in patients with Klinefelter syndrome, patients who have had an orchitis, also trauma to the testes or even direct radiation to the testes, leading to gynecomastia. And in secondary hypogonadism due to pituitary failure. Cause could be non-functioning pituitary adenoma. There is low levels of LH and FSH, and subsequently low testosterone as well. Another case in point will be prolactinomas, which is a functional pituitary adenoma where low LH and FSH, which are the gonadotropes, results in low testosterone as well, which subsequently leads to a disproportionate increase in estrogen to testosterone in the breast tissue and promoting gynecomastia as well. So there are some other causes, and we'll look at the pathophysiology of that as well. Chronic liver disease causes increased adrenal androgens, and which enhances aromatization of androgens, and this leads to increased estrogen. Also, remember, as I mentioned earlier, some of these patients are on spironolactone for ascites or decompensated liver disease, and this can also contribute to gynecomastia. How about patients who are cachectic from malnutrition? These patients actually have secondary hypogonadism as the cause of gynecomastia. And then tumors that produce HCG are also a known cause, and testicular germ cell tumors, choriocarcinomas, embryonal carcinomas. These can cause increase and release of HCG, and HCG acting similar to LH. Remember the alpha subunit. Okay, so acting just like LH would result in increased testosterone production by the Leydig cells of the testes, and of course peripheral aromatization of testosterone, and consequently increase in estrogen levels as well. Well, how about hypothyroidism? Well, with hypothyroidism, about 25% of patients, of hypothyroid patients, can also present with gynecomastia, and it's important to be on the lookout for this in some patients. And the reason for this is that there's increased LH and increased testosterone production, peripheral aromatization, and increase to estrogen, as we had described earlier. And also, hypothyroidism results in increased sex hormone binding globulin, and this binds to the free portion of testosterone, reducing the levels of free testosterone, and this shifts the ratio in favor of a hyperestrogenic state. And then it's also important to look at rare adrenal tumors, especially adrenocortical carcinomas, because these can also be a cause of excess estrogen production in these patients. And then sometimes, despite a thorough workup, there's no identifiable cause for this hormonal imbalance, and we will just use the term, as usual, idiopathic. So what is a diagnostic evaluation? So to have a thorough diagnostic evaluation, we'll be looking at the possible etiologies as well that would guide us in our diagnostic evaluation. Knowing the duration is relevant, because typically if it's greater than 1 year, it's less likely to improve with medications. The common medication we use for this will be tamoxifen. Okay. And also from history taking, as we mentioned earlier, a bunch of medications, spironolactone, cimetidine, alkylating agents that can cause gynecomastia. So taking a thorough history to tease that out, and then looking at systemic diseases as well. Chronic liver disease would be a typical condition to look at. And then we need to distinguish lipomastia from true gynecomastia. So palpating the breast tissue in the subareolar region, and we showed that in the earlier slide, that would help you distinguish gynecomastia from pseudogynecomastia or lipomastia. And then ordering the appropriate hormones. So we'll check testosterone, estrogen, LH, FSH, gonadotropes. HCG is relevant, TSH as well to screen for hypothyroidism, and then prolactin levels. Liver function tests, especially in patients with suspected alcoholic liver disease, and then thyroid function test in these patients. Of course, renal function test. So imaging can be very supportive. So testicular ultrasound, if testicular mass is suspected, will help in screening for germ cell tumors. And then mammography if breast cancer is suspected based on palpation of the breast. And then pituitary imaging if secondary hypogonadism is indicated. So because in these patients they may very well have a prolactinoma, they could sometimes even have non-functional pituitary adenomas as well. Okay, so remember that non-functional pituitary adenomas can press on gonadotrophs. Okay, and these are actually some of the first cells to be destroyed during pituitary cellular masses, during expansion of pituitary cellular masses. So gonadotrophs can be lost, and this can present with hypogonadism, resulting in low testosterone and an imbalance in testosterone to estrogen ratio. Okay. So these are the key summaries or takeaways from this, that gynecomastia involves glandular tissue proliferation due to an imbalance in androgen and estrogen activity. There are known physiologic causes, which could be neonatal, especially with transplacental transfer of estrogen, pubertal during the growth spurt, and involutional related to aging and a decline in testosterone levels in men. Pathologic causes could be multifactorial, but looking at the medalist is important, and then screening for endocrine dysfunction, mainly hypogonadism and hyperthyroidism, and also looking for liver disease and testicular tumors, especially the germ cell tumors. So the evaluation requires distinguishing true gynecomastia from pseudo gynecomastia and malignancy, and then doing targeted therapies. And I'll also like to sign off by saying that in patients with idiopathic gynecomastia, okay, so idiopathic gynecomastia, less than a year, because there is less fibroblast proliferation in these tissues, you can actually use tamoxifen as well, okay, to block this selective estrogen receptor modulator, block the effects of excess estrogen compared to testosterone. So those would be the key takeaways. And of course, if it's been more than a year, then you can send that patient to a plastic surgeon and have it reduced or removed. So thanks for joining me today in this short presentation. I'm looking forward to seeing you in future videos. Do subscribe to this channel if you want me to continue making these videos. I really enjoy making them. Once again, thanks for joining me.